and that's all I'm going to talk about. So I will escape and let Venkat take over. Plenty of chance over the next few days. Okay.
So I fully agree with what Dr. Donald was saying about the clinical examination for respiratory, because I'm a respiratory physician. So you can start either at the front or the back. There is, it is an international exam. So candidates, take the exam all over the world. So there isn't one sort of, structure, which is right. So any structure which basically covers, your basic inspection, palpation, percussion, and auscultation would sort of suffice. Physician in internal medicine and respiratory medicine. I work in the east of England, and as Dr. Saudullah said, I was one of the the founding members of this course. The main motivation, for such a course is that I too, sort of a product, from one of the Indian colleges from Chennai, from Madras Medical College. And in fact, I was one of the examiners in the first sort of PACES exam that was conducted in Chennai in 2005. And to me, it seemed at that time that, half the candidates had come to the exam just to see what the exam was like. And I was quite appalled at the end of, sort of 3 days of the exam that we had a pass percentage of about 13%. And, I really felt that there was a dire need, for a course in India so that the candidates can familiarize themselves with what is actually required. And as Dr. Donald, sort of referred, if you know the system, if you know what exactly, the technique of the exam, the system, then you have a far higher chance of sort of getting through. Okay, so that with that preamble, we will approach the history taking. Where is the why take a history? So we are all physicians, okay, and basically, it is a major piece, of the jigsaw. It allows you to sort of communicate, with patients and colleagues. Where I trained, my professor used to say that if you take a good history, then you should be able to, in the majority of cases, even before laying a finger on the patient, you should be able to know, or get a differential diagnosis of what is wrong with the patient. And I think that we are all physicians because, we have mastered, or we are good, at sort of communicating, compared to, I'm sure, some of your colleagues that may have gone on to become surgeons or anesthetists, where you can get away with just, basic sort of communication skills. Whereas as a physician, you spend a lot of time, talking to patients. So I think that this is one area which will stand you in good stead, across the whole exam. So, so it may give you the diagnosis, as I said, it establishes the facts or the chronology, as we call it, and then, gone are the days, when, you found it very difficult to read, your doctor's handwriting. I think that, I do see, what candidates write, when they scribble on these blank sheets of paper that we give them, and the writing has sort of improved, over time. So first impressions, are the best impression. So, when you appear, for the exam, you have to, just forget, about the past. There may be, a few of you who may have done the exam before, but the examiners don't know that. So you have to give your best, performance on the day. And it is, you have to, play act, there. So that patient or that surrogate in front of you, is someone that you will be lavishing all your attention, over that 20 minutes or whatever time, that you've got. So, you have to, the first thing that you do is to introduce, yourself. So you will say that, look, your doctor has, sent you to me, for this purpose, and I wish to take a history, and is that all right? Okay. And then the body language is sort of very important, so you have to, that there is no point in sitting there and not sort of engaging, with the patient. So it's very important, that you sort of do that, maintain, eye-level contact, so quite a lot of times as examiners, we find candidates, who give the impression that they would much rather be somewhere else. So that, 14 minutes that you spend, is very, very important, okay? And then you ask, a sort of a combination of open and closed questions. Do you know what that means? So, let's say that, somebody's been sent in because of, chest pain or breathlessness. So you can ask them, to start off with, can you tell me a little bit more, about your chest pain? And they may say, oh, they may tell you something. So a closed question is when you're just asking them, is it a dull pain or a sharp pain, is an example of a closed question, whereas an open question is just, asking them to just describe, what they've got. The other thing, very often, I see candidates bombarding the surrogate with numerous questions, but they don't, wait to hear the answer. Okay, so one of the things I want you to practice is to listen. So if you ask a question, give the surrogate, enough time to, finish answering the question. Okay, it's actually a lot better when you have a surrogate, and you will have a surrogate in, in almost all the centers that you go to, and that's actually much better than talking to your real patient who might sort of ramble on. Okay, and so, one of the ways that the exam has been standardized is that the surrogate will tell each candidate almost identical, so they won't be telling another candidate something else. So that is the whole point of the calibration that Dr. Donald was sort of telling you about, so the two examiners, they will be spending, about half an hour, 45 minutes, just making sure that the surrogate, gives the same history every time, they are asked. And the last one is very important, and what a lot of what I'm going to tell you, applies not only to history taking, but also the communication skills station as well. So, the patient, might, it may be a situation of, say, as the patient was giving you the history, they may sort of, say that they're very worried that they might have cancer. That may be one of their concerns, because of a family history of cancer, or they lost another close relative to cancer. And at that stage, I have seen candidates, because they've got a list of things that they want to quickly rattle on. So they, I've seen candidates actually do this. Yes, 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 good, 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 without actually saying, oh, I'm so sorry, to hear this, I will address your concern, towards the end of the consultation. So you acknowledge, that the patient has expressed a concern, and you will, then, deal with it at a later stage, at a more appropriate time. Okay? So that is important. So the key components of taking a good history, are all these things. Now, you don't need to really write this down, because this should be just like a quick revision for you. Okay? But so there will be a presenting complaint, that will be there in the letter, that you are given to read, and you're given the letter to read 5 minutes before you go into the station. So in the talking stations, which is station 1, in station 2, 4, and 5, you actually have 5 minutes before you enter the room when you actually have, the reading material, okay? So, you will elicit, the history of the presenting complaint, and then you go through the past medical history, drug and allergy history, family history, psychosocial history, all those things. So this shouldn't be sort of news to you, okay? Now, because, these things are so important, this is just an example, of the mark sheet. And, I'll just read out, key things. So satisfactory means elicits presenting complaint, systems review, past history, family and medication history in a thorough, systematic, fluent, and professional manner. Okay? Assesses impact of symptoms on the patient's occupation, lifestyle, and activities of daily life. So, you may have done the first bit, but it's important to assess how their symptoms are actually impacting their job or their occupation, their lifestyle, what restrictions, does that place upon what they can do, okay? So that is important. So if you've done all that the examiner has to do is to mark satisfactory. They will just shade that with a pencil on the top. But if it is borderline or it's not unsatisfactory, then we've got to write all the comments on the extreme, right-hand corner. Okay, so and the various clinical skills are there in the bottom, and we will look at that in a bit more detail. And this is the bottom half of the mark sheet. Okay, so managing patients' concerns. So you have to ask, the surrogate before, you finish whether they've got any concerns. And they have been coached to ask you, one or two specific concerns, and the examiners will be watching how you deal with that. And then the differential diagnosis, again, I will stress what Dr. Donald has already told you. So if somebody, presents with, a particular symptom, say jaundice, and, you are sitting the exam in India, we would expect you to give a differential diagnosis which is relevant to the local sort of, health sort of economy, rather than give us something which is quite exotic. And then clinical judgment is basically, it says selects a comprehensive, sensible, and appropriate management plan. So clinical judgment basically means, whether you are able to initiate a sensible investigation and management plan. Okay? And then maintaining patient welfare treats the patient respectfully and sensitively and ensures comfort, safety, and dignity. So the, as we said, 100% of the candidates, as long as, you treat the patient with respect, then you do not have to worry. So where, we do mark the candidate as sort of unsatisfactory is, they do not empathize with the patient. So they cause some kind of emotional distress by not acknowledging the patient's concerns, or not being sort of quite empathetic with the situation. Or in the clinical examination stations, when you're examining, you actually cause the patient discomfort, and in spite of the patient, so you've got to pick up all the cues, and in spite of the patient sort of, telling you that you're causing discomfort, you carry on with the examination, then, that would be an example of, sort of what we call, causing the patient discomfort, and you'll be marked down for that. Okay, so this is the candidate form. So this is what, you will be given, and you read for 5 minutes before you go into the station. Okay, so it will say patient details will be Mr. X or Mrs. Y. Your role. It will say that you are the the senior house officer, in the acute medical unit, or in the neurology clinic or the rheumatology clinic, And the presenting complaint, there'll be just a brief thing, patient presenting with knee tiredness, or breathlessness, or joint pains, there'll be just one line there. And then, it says here, please read the letter printed below. When the bell sounds, enter the room. You have 14 minutes to take a history from the patient, 1 minute to collect your thoughts, and 5 minutes for discussion. You may make notes if you wish, and you will be given some blank paper. And what you do in those 5 minutes with the blank paper is just to spell out these various headings that were there, and quickly jot down the points that you would like to clarify once you get inside the room. And it will say, dear doctor, and it will just give, usually it will be just 2 or 3 lines of what the patient presented with, and the doctor will say, we would appreciate your opinion, on further management or something along those lines. Okay, so your task, it says there in the bottom, is to interview the patient, and based on the history you obtain, construct a differential diagnosis and plan for investigation. You should explain these to the patient and answer any questions they may have. And they will have definitely 1 or 2 questions that we want you to address. This is the form which the surrogate would have been given. Okay, and this is an exact replica of the form used in the exam. So they will be given, this form to read. Okay, and during the calibration process, which is where all the examiners have gone, now to meet up with, their own surrogates, they will run this history through with them and make sure that the surrogate also is fully familiar, and they tell all the candidates the same history, so that there isn't very much discrepancy. Okay, but again, you can see that it follows the same pattern I was sort of telling you. So you have to follow this structure, and it makes it a lot more easier. And again, lifestyle, occupation, travel, family, patients, concerns, expectations, and wishes. So that's there right at the bottom, and usually there will be 1 or 2 questions there. So what I would suggest that you do, having coached, hundreds of candidates, over the past 2 decades, is that you've got 14 minutes. So you had 5 minutes to read the letter and plan the interview in your mind. And as soon as you go in, you have 14 minutes with the surrogate. So, you plan the structure logically, okay? And spend 5 minutes exploring the presenting complaint. So that is the most, important thing. So whether it's chest pain or breathlessness, just, explore that in detail. And then you spend, roughly 3 to 4 minutes on the past medical history, the drugs, the social, and the family history. And when you take the social history, what we actually want you to do is to take, also, how does that impact, on their job, on their relationships, all those sorts of things. 2 minutes taking an occupational history, and you have to leave at least 2 to 3 minutes to review the information with the patient and answer any specific queries. So what I mean by that is, at the end of 12 minutes, there will be 2 minutes remaining, and the examiners will warn you that 2 minutes are left. So if you haven't come down to a review of the information, that is the opportunity to do that. So you will say, Mr. Brown, so far, you've told me that, you've got a 6-month history of gradually progressive breathlessness, and that sometimes you wake up at night with this breathlessness, you use 3 to 4 pillows, at night. You've already been tried on some medication which hasn't helped. And you have expressed to me your concerns that we might be dealing with something serious or sinister, okay? And you have a family history of lung cancer. Is there anything else? Is there anything I have missed? So you just summarize it very briefly right at the end, and then you ask them, is there any specific questions that you've got? And that's when they will come up with it. And then what happens at the end of 14 minutes is the surrogate will leave the room, and you've got just 1 minute just to collect your thoughts and, present to the examiners, okay? So the presenting complaint, maybe sort of several. And so what I suggest you do, is just explore each in turn. So there may not be one presenting complaint. For example, somebody presenting with breathlessness may also have a cough. They may have hemoptysis. They may have lost weight. So there may be a few things there. And so you explore them one by one. That's why I said spend the most time on the history of the presenting complaint. Now, this is just a general scheme, irrespective of what symptom the patient has, in the history. So onset, character, progression, any precipitating or relieving factors. Is there any other associated features? Have they tried any treatments? Is there any previous episodes similar to this? And what is their impact on life? Okay, so that's just a general scheme. Again, whatever I'm telling you, this is not rocket science. Those of you who have some experience may have been doing this already. And all that I'm sort of doing is just to reinforce the key, points. Childhood problems, again, somebody presenting with a chronic cough, for example, it's very important to ask them about, childhood history of, whooping cough, measles, that kind of a thing, because then, part of the differential diagnosis, you can think about conditions such as cystic fibrosis or bronchiectasis, depending on the age of the patient. Drug history, ask about what medications they take. Most of the time, the surrogate will show you a piece of paper, with whatever medications they are on. It's so much easier, okay? And then you ask them about allergy. So it's not enough just to write, patient said they're allergic to penicillin. It would actually be helpful to know, what exactly happened and when. Because there are patients in real life who tell you, oh, I was told, in childhood, but I don't know anything about it. For example, allergy to penicillin. That is the most spurious allergy, that you sort of hear about. Okay, so it's interesting. It'll be useful to know, whether they had a rash or whether they could actually remember what, the allergy was. And in drugs, it's also important that sometimes, particularly in India, patients may be taking certain allopathic medications, but they may be also taking some alternative medicines such as homeopathy or Ayurvedic medicine, or they may be using some health tonics, which they may not need a prescription, So again, it's important to know whether they buy, whether they take anything else apart from that which is prescribed, okay? And in the UK, I think one or two of you were going to take it from the UK, it is called over-the-counter medication, or OTC. Do you take any other medications that you're not prescribed? Very important to find out about alcohol and smoking history. So alcohol, just for your information, until a few years ago, it was considered that, the safe limit, for alcohol consumption was 14 units for women and 21 units for men. Somehow, men were considered to be superior in terms of retaining their propensity for tolerating alcohol. But, a lot of research over the past few years have shown that that is not correct. Men are equally susceptible to the effects of alcohol abuse. So basically, in men and women, in both, the legal limit is sort of 14 units. Okay, and that is roughly, if you there's sort of various measures, you can sort of look up. Okay, and then history of blood transfusions, again, is sort of important because there's been a lot of patients who have contracted hepatitis C, because of transfusions in the past and, various other transfusion-borne illnesses. Personal, social, and family history, again, ask about, their home environment, ask if they've got any pets, family setup, job, travel, do they have any carers, family tree, it is not relevant in all specialities, but there are one or two specific scenarios particularly in the communication skills, where you might be asked to explain to somebody that they've got polycystic kidney disease or celiac disease or something, and it'll be helpful just to have a quick family tree, which isn't going to take you more than a minute to draw. Again, all these things doesn't apply to every scenario, so you just have to adapt it to the particular scenario you're given. So in my own specialty of respiratory, the occupation is very, very important. Asbestos, dusts, we always ask about pets, because of things like extrinsic allergic alveolitis, bird fanciers lung, that sort of a thing, and any exotic travel, particularly with SARS and, that sort of illnesses that patients have experienced over the past decade. Systems review, is specifics of each body system, and some initial non-specific symptoms would be what we call generic symptoms that you explore irrespective of what history, you're asked to take. So generic, so this you will ask every patient, about their appetite, whether, they've lost weight or gained weight, general malaise, lethargy, tiredness, whether they, any difficulty with their sleep, whether they have any, itching, fever, night sweats. So this is basically a generic symptom. And then we'll quickly run through, you don't need to take any notes. I think most of you will be familiar with this, but if you take the cardiovascular system, those are all the symptoms that you will ask the patient. If you take the gastrointestinal system, so if it is the predominant symptom is something, along those, say somebody's been referred with a change in bowel habits, then you will explore all those things. Okay. Genitourinary, not that many questions in the bank, for good reason, because I know that, generally candidates from particularly the Indian subcontinent, they feel very delicate to ask, some of these sensitive questions. So it is just as well you can be relieved that there aren't that many symptoms pertaining to, genitourinary or, sexual history scenarios like HIV and AIDS. Rheumatological, you will ask all these symptoms. Again, no great surprises there. Endocrine, neck swelling, tremor, thirst, any change in their hand size, voice changes, skin changes, hair changes. Okay, reproductive history, have they had any miscarriages? Have they experienced any issues in pregnancy? Neurological, once you have the structure in your mind, whatever the history of the presenting complaint, you can adapt your history taking accordingly. Hematological, swollen glands, have they had any, blood clots in the past? Is there any history of either easy bruising or excessive bleeding? Have they had any frequent infections? And whether they have noticed